Hi, Muhammad.
Hi,
Nice hat.
good evening.
Nice hat.
Thank you.
Hi, Angeliki.
Hi there. Sorry, I was muted.
No worries. Which center are you from?
I'm from the Nahlén Bamber Foundation. I'm a psychologist.
Okay. Yeah, I'm locating faces. Hi, Justin. Bonjour.
Hello. How are
Hello.
you?
Good. Comme ça va?
Okay, thank you. Fine, fine. Glad to meet you.
Yes. Okay, so I think we're gonna start.
This is William from Kenya.
Hello, William.
Oh,
from
hello,
Imlos.
Beta. How are you?
Good, good. Good to have you here.
Okay, thank you.
Yes. Nice. So I think we're all ready. Today I'm alone on the technical side and moderating, so bear with me if I'm slow responding. But I think we'll manage. We've been in these spaces before many times. So yeah, I'm just gonna start. Welcome everyone. Good to see you all online. Well, as every webinar, remember that we have simultaneous interpretation available from English to French and Spanish. So make sure you're on the right channel. You can choose your channel under the interpretation icon at the bottom bar. We encourage you also to participate, as always, in the discussion by raising your hand on the reaction button bar or activating your mic during the Q&A and open discussion spaces. So, yes, welcome everyone. And this webinar will be focusing on screening, documentation, and monitoring of torture in children. And we have 4 fantastic speakers that will help us delve into the topic. Ronak, Catarina, Laure, and Kim, thank you for being with us and sharing your experience. Each speaker will have 20 minutes to present. And then after each presentation, we'll dedicate 5 minutes for questions. But there will be also a final open discussion at the end with the remaining time left. So yeah, but before we start, I actually also wanted to refer to an article from our torture journal back from 2009. I'm going to share this in the link. And it states how vital it is to focus on torture in children. It also mentions or points out how it is a significant worldwide problem, but that there are no official or reliable independent statistics to measure it. Hence, the importance that we talk about several perspectives on this and how different methodologies can be used to do that. Without further comments, I'm going to share the link here in the chat for everyone. And you can always refer to the journal for further knowledge. Okay, so I'm going to start introducing the first 2 speakers, Ronak and Catarina. They're from the Swedish Red Cross. Ronak is a clinical psychologist, and Catarina is a PhD at the Department of Health Sciences at the Swedish Red Cross University in Huddinge in Sweden. Sorry if I didn't pronounce it correctly. But with that, the floor is yours.
Yes, I'm going to start sharing the presentation.
Yes.
Do you all see?
Yes, perfect.
Yes. So thank you so much for inviting us here today to talk about this very important and also current issue. Yes, you had a great introduction already, so I guess we can move forward. Catarina.
Yes. Today we will talk a little bit about a literature review that we have conducted on screening, documentation, and treatment for torture injuries in children. And this subject hasn't been studied earlier, as far as we know. And this study is a part of a 3-year project on children and torture, with the overall aim to collect, develop, and spread knowledge about the identification and treatment for torture injuries in children. But let's just start by a few words about torture in children. So from what we know, children have probably always been subjected to torture in some kind of form. And in many parts of the world, this is still happening to many children today. We also know that that torture is associated with serious health consequences, and that this is especially true when children are subjected to torture. But despite these facts, the issue of torture in children have been very absent, both from the field of research, but also from the global policy. And as a result of that, there are very few cases of torture in children that are identified, and few children are offered torture rehabilitation, which is of course very alarming. So we did a broad search in scientific databases, which generated about 5,000 hits. And we also included so-called grey literature, which means reports, guidelines, and healthcare programs. And after screening for eligibility, we included 80 scientific articles and 6 so-called grey literature. And then we categorized this included literature into screening, documentation, or treatment.
Yes, so just a few words about the study samples, which were very similar in most of the studies. So the main study populations included refugee children, children in war and political conflicts, and child soldiers. And extremely few study samples included only child survivors of torture. And very few studies also included the youngest children, those under the age of 6. And here's just an overview of where the studies had been conducted. So in total, there are 30 countries represented here.
Yes, and we looked at methods of how they had screened for torture exposure, and there were mainly 2 methods of screening for that. It was either via screening instruments or by doing interviews, which was not based from a screening instrument.
And we also looked at how often they asked for who the perpetrator was, and we saw that in less than half of the studies they had asked about the perpetrator.
Yes. So regarding the torture screening, I will just briefly highlight some of the findings. So in the questionnaires that we found, torture was usually addressed among other difficult life events. And most questionnaires were originally designed for an adult population. And we also found that some of the questionnaires included the word or the term torture in their questions without any further explanation of the word, which can be a very complicated concept even for us to understand. So in other words, we identified some potential areas of improvement here. And regarding the screening for torture injuries, one very clear tendency was the overrepresentation of the psychological and psychiatric screening compared to screening for physical injuries, as you can see here. And as you can see here, the documentation of torture injuries was dominated by physical injuries. Only a minority of the studies included documentation of psychological or psychiatric injuries. So as you might notice, there was an opposite trend here to the screening studies, which was dominated by the psychological screening. And one explanation to this imbalance could be the fact that the documentation was mainly conducted by medical doctors in the studies. So yeah, you find what you look for.
Yes, and now we move on to the studies that had different treatments for children who have survived torture. The study population we included were children and young adults. And there were 13 studies that we found that had done some interventions. Only 2 of these studies involved the youngest children, younger than 7 years. There were mainly 2 study designs of these treatment studies. They were either randomized control study, where the participants are either randomized to get the intervention or be in a control group, or it was non-randomized study of intervention. That means that they only had intervention group and no control group. And the main outcome that was measured in these treatment studies was mostly PTSD, followed by depression and anxiety, behavioral problems, and pro-social behavior.
So the treatment interventions in the studies were categorized into 3 groups. So the first group included some of the more well-known trauma treatments for children, such as trauma-focused cognitive behavior therapy and narrative exposure therapy for children. The second group included the mental health programs given by the MSF. And the third group included mixed treatments with a varying focus on trauma interventions.
Yes, and those who were randomized to control group were either randomized to a waiting list, which means that they got the intervention after the study was done, or there were some studies that also had an active control group. That means that they got some kind of intervention, but not the one intervention they wanted to study. We also saw in some of the studies that they had to shorten the waiting list due to ethical reasons, that they didn't want to have the children waiting for a potential beneficial intervention. And the follow-up after the treatment was given, there was a variation between a short-term follow-up and a long-term follow-up, where 8 studies had a short-term follow-up up to 4 months, and the remaining studies had a longer follow-up of between 6 to 12 months. And now I'm going to talk a bit about the effect we saw from these different interventions. And the red is a statistical significant effect based on where they have done analysis between the intervention group and the control group. And the pink means that they only have done analysis within the group who got the intervention. They have not compared with a control group. And the gray is non-statistical finding. And what we saw here was that trauma-focused cognitive behavioral therapy and narrative exposure therapy significantly reduced symptoms of PTSD from 3 months up to 1 year after the end of treatment in the children who some had survived torture. In 2 of the interventions with the varying trauma-focused elements, there were 2 who contained exposure, and they both significantly reduced symptoms of PTSD within the treatment group. We also looked at how the effect was if you compared those treatments who were individually based and those who were group-based. And we could see that both individual and group-based treatment reduced symptoms of PTSD significantly. Concerning depression and anxiety, it was difficult to draw any conclusion because it was only measured in 1 study that was individually based and 5 studies that were group-based. But overall, it seemed like both formats had a positive effect. We also looked at the intensity of the intervention. So we compared those interventions that had a normal intensity, which means they had a treatment once a week for 90 minutes, and compared it to interventions that were more intensified than that. And we could see that both normal and intensified intervention had a positive effect on reducing symptoms of PTSD. However, you could say that the evidence was slightly higher for the more intensified interventions, since the analysis were to a greater extent based on analysis of between groups. There are always in scientific studies methodological considerations you have to consider due to we saw an heterogeneity in the study samples with different age, different trauma events, type of interventions, and they have used different instruments to measure the outcomes. So it is difficult to draw a conclusion specifically concerning child survivors of torture, since the sample in many cases also included children who had not been subjected to torture, but general war experiences, for example. Yes. But we can still draw some conclusions from all the findings that we found. And that is that many existing trauma screening instruments are deficient in screening for torture, because, for instance, many of them don't ask about the perpetrator. And as was earlier mentioned, that children were mainly screened for psychological injuries, but when it came to documentation, it was mainly physical injuries that was documented. Trauma-focused cognitive behavioral therapy and narrative exposure therapy had a significant effect on reducing symptoms of PTSD. And we also saw on other psychological outcome measures as well. And finally, both individual and group-based treatment, as well as normal and a more intensified treatment, were shown to reduce symptoms of PTSD significantly.
All right, so the final slide regarding suggestions for the future, and the list is long, but time is short, so I will just mention a few points. So one suggestion would be to develop a new screening questionnaire to better identify torture, but also torture injuries in children. It would also be interesting to evaluate group and intensive treatment for child torture survivors. And finally, another suggestion would be to include other measure outcomes when evaluating treatment. For instance, functional level, quality of life, and attachment quality among children.
Thank you, Ronak and Catarina. That was super sharp timing. Really good. Thank you, thank you. And it's good that you also leave, point out these three kind of gaps to be addressed in the future, or challenges maybe. But yeah, thank you for your presentation. Now we open 5 minutes for questions or Q&A. Does anyone have a question? Feel free to jump on mic. Sunita. Sorry, Sunita, I thought you were going to say something. You know how it goes. You can activate your mic. Go ahead, Alexis or Sunita. I think, Sunita, maybe you can go first if you have a question. Otherwise, Alexis. Allez-y.
Bonjour.
Oui, ma question réside... bon, j'ai bien suivi l'intervention de Ronak, Catarina. Moi, je suis beaucoup focalisé sur le problème d'enfants sourds-muets. Est-ce qu'ils peuvent nous aider avec des stratégies? Comment ils peuvent arriver à découvrir les symptômes psychologiques pour un enfant sourd-muet et arriver à réduire ces symptômes post-traumatiques?
I'm not sure, Ronak and Catarina, if you got the translation?
No.
No, unfortunately not.
You weren't in the English channel, right? So you see there's an interpretation button in the bottom part of the Zoom app, the Zoom. Well, anyway, I can just translate. Alexis was saying that he's normally he works a lot with blind and deaf children, and he's asking if you have any specific strategies, if I understood correct, on working with this specific population.
Unfortunately, not. But that is a very good example of one of many areas that we should develop. How to see, how to evaluate different expressions of symptoms, and how to meet the needs of all children. So that's a great question, but unfortunately, I don't have any experience in that field.
It's okay. Well, Alexis, I can see, yeah, that can be challenging. Vainqueur, est-ce que vous avez une question? And then we have Shirley. So Vainqueur first. And you make sure Catarina and Ronak to be on the interpretation on the English channel.
How do we do that? I'm sorry. Is it
Yeah,
like
you go to the, it's like a globe icon. If you don't have it.
Okay, now I
Yes,
see.
thank you. Yeah.
And I press English.
Yes, you play English, and then you're in you get the English interpretation.
Okay, thank you.
Yes. Alors, Vainqueur, we're ready.
Merci de m'avoir accordé la parole. J'avais tout simplement une préoccupation quand j'ai écouté la présentatrice parler du but de l'étude, qui était de collecter, de diffuser les éléments des connaissances. Alors je me suis dit, cette diffusion s'est faite par quel canal et en quelle langue? Elle a été faite quand? C'est une première préoccupation. Et la deuxième, nous savons que les enfants en fait, n'ont pas une attention soutenue, surtout que s'il faut les accompagner, s'il faut les aider dans la détraumatisation. Est-ce que ces enfants-là ne constituent pas pour eux un obstacle pour leur détraumatisation, parce que de temps en temps, peut-être ils n'ont pas cette volonté de suivre des séances? Merci beaucoup.
Okay, so I will answer the first question. So I think you referred to the last slide about the future, maybe about the future suggestions of research. And we are actually planning within the frame of this this project to develop a new questionnaire within the Swedish Red Cross, but our hope is that it could be translated into more languages. So I hope that could be shared with all of you in the future. But if you have any special questions about that, you could always reach out to me or Catarina afterwards, and we will try to answer those questions. And regarding the attention of how the challenge to make children pay attention in the frame of the clinical research. Did I understand the question correctly? If that's the case, of course that is difficult, but that also highlights the importance for the researchers to also have some experience with children
how to adapt the environment, how to adapt the questions and the settings to the needs of children. Take many breaks, bring different objects, plays, and so on to attract the children to participate. But yes, that is of course a challenge for many.
Yeah, and we also saw, I mean, the youngest children generally, not just in these kind of studies, but generally are excluded in research because of the young age. And I think it's important that they also get involved, and you need to find methods that works for the youngest children as well.
Thank you, Catarina and Ronak and Vancouver, for your question. I can see Shirley has also her hand up.
Yes, I do. Thank you. I want to raise the question of the exclusion of children in many truth commissions, including the South African Truth Commission. And so children were not included in the category of persons whose rights were violated. And this is one of the categories that even 20 years later, 25 years later, since the TRC report was handed over, we're still looking at and still considering, because we don't think that a closed list is appropriate because there were so many categories of people left out. So, I mean, in answer to the first question about blind and deaf children, and the second question about language, in my experience, art therapy is a good way to tap into what children are, what is troubling them, and even play therapy. So I think we have to work at the language of children rather than impose our sophisticated research tools to look at this question. Secondly, I think that longitudinal studies is very important with children. When later down the line, they can find the words to speak about the horrors that they experienced that they could not find words for when they were very little. And maybe not even as adults will they find those words. But I think, especially when looking at children, we should have a longitudinal approach. Thank you.
Yeah, we agree with that. It's we also see that there is a lack of long-term follow-up studies. So that is definitely a very good idea to have longitudinal studies.
Good. And if we don't have any other questions, I don't see any other hands raised. Or I do see a comment in the chat from Justin. He's asking, what does it mean trauma screen instrument and the methods of torture children are most faced? I think these are two things. But yeah, feel free, Catarina and Ronak, to answer to that. I think that was your presentation that was all about, right?
Sorry, I didn't. Could you read that again?
Yeah, it's in the chat. Justin is asking, what does it mean trauma screen instrument and the methods of torture children are most faced? So I think these are two things.
Okay. So trauma screening instruments would be, I mean, the way we talked about it here would be questionnaires, like a list of different questions to identify torture and torture injuries in children. And these questionnaires could be filled in both of children and their caregivers. So that's what we mean when we talk about it. And the second question, the methods of torture, you mean methods, the torture methods that children are subjected to? from what we have found, there is not a very big difference actually between the methods that adults are subjected to compared to the ones that children are subjected to. One difference could be that children are more often witnessing torture that is directed to their caregivers or other important adults. I would say that's the main difference that I come up with right now.
Thanks, Ronak. I'm also seeing in the chat, Mohammed asks if you mind sharing the findings of your study about the ratio of psychosomatic disorder in the sample population. Feel free to send that to me, Ronak, and I can upload it in the FABO in our e-learning platform, or share it with the participants.
If we can share the report, was that the question? The findings?
The findings of the study about the ratio of psychosomatic disorder in the sample population.
I think maybe that's a question to you, Catarina.
Yeah, I don't think we particularly looked at the ratings of psychosomatic disorders. We looked at the screening and documentation and treatment of children who survived torture.
Okay, so
was
Mohammed,
it a specific part that you were wondering about, Mohammed? Maybe we misunderstood the question.
Yeah. This was about the psychosomatic disorder. This is the most common about in the torture victims. So you were talking about the children, and I was wondering that I might have missed the portion you was discussing about this. This is quite natural that when somebody is whether a children are a child or adult is exposed to the torture, the other mental problems are faced, or he confronts, he or she confronts. It's certainly it's impact the body also, the sort of problem, indigestion, headache, insomnia, sleeplessness. These are the, which I have studied so far, are the psychosomatic problems that are directly linked to the torture. So I was wondering that if you have a certain ratio found out from your study.
It was difficult to draw any conclusions about that because many of the samples were mixed samples. They were mixed children and adults, and there were mixed samples concerning children who have experienced general war trauma and children who had specifically been subject to torture. So it was difficult to see any specific link between what they had been exposed to and their mental state. There was very few studies that had done that kind of analysis. So unfortunately, that was very difficult to draw any conclusions about that.
If I'm allowed to put another question, in your future direction for clinic and research, you have mentioned at the end of the future direction, long-term follow-up and functional impairment as an outcome measure. So would you mind guiding us that especially those who are working in the prison environment, where they're especially the children come for a very brief time. They spend hardly 2 months, 3 months, 4 months, maximum 6 months. Those who are under trial, I'm talking about. How can we ensure that their treatment could not? We won't be able to continue our treatment. So, what would you suggest about those who are who come for a short time, 3 months, 2 months, what could be the strategy we are supposed to follow?
I don't know if I understood correctly, but I think it'll follow for at least 1 year after you're given a treatment. I think it would be a good idea. But as was mentioned earlier, even a longer time for doing an actual longitudinal studies as well. But 2 or 3 months is not very long.
Yeah.
Well, thank you. I'm mindful of the time, and I can see there's still another question from Timea in the chat. Timea, do you mind if we take it at the end with the open discussion? Otherwise, Ronak and Catarina, feel free to also answer in the chat. She's asking about the, you know, if the publication of a study is basically limited by the ethical issues, right? By consent issues of the participants. And maybe that's why there are not enough studies. But if you don't mind, let's take it at the end, because we have the other speakers ready. And with that, I will introduce Laure Elmaleh. I'm sorry for my pronunciation again. Laure works at OMCT at the Child Protection Against Torture program. So Laure, the floor is yours.
Thank you very much, Marita. So I'm just trying to share my screen. It's very nice to be here. Do you see my screen?
Yes.
Yes.
Maybe you can make it full screen though. Right now is the PowerPoint.
Right.
If you click, I think it's on this position. Maybe here. Yeah, mode présentateur. The third one here.
Sorry about
Yes.
my lack of technology skills.
No, it's fine.
So thank you very much for having me, and I'll focus today on what the OMCT does together with its partner, its network members, about preventing and documenting, monitoring child torture. We try to, so I'll start. OMCT, just to sum up, we exist since 1986, and basically our child protection against torture program started not long after that. So almost 3 decades ago, and currently we work specifically on children in 7 countries. That's Benin, Uruguay, the Philippines, Togo, Brazil, Nepal, and Honduras. And basically, the reason why we started to focus on children, and the reason why we also continue, it's been said a little bit by my colleagues during the previous presentation, but basically, children are most of the time invisible. Torture even more so. It's very difficult for children to speak up, to report, to even know what torture is, to even know their rights, to even know that those practices are prohibited, that adults cannot, I mean, most of the time perpetrators are adults, that they cannot inflict these types of either physical punishment or psychological practices on children. And we see that still today, it's something, as been said, it's very invisible and not included in any global policies. Sometimes also what the practices that are inflicted on children are not considered torture by the authorities, whether at national level, but also in the common understanding at international level. Sometimes some authorities find a line between what they see as a relevant form of discipline and what is actually torture very very fine, and so that all sort of and something that's tolerated. So that's a lot of reasons why torture of children has been so little reported on. And as also has been said, the specific impact on torture of children is more serious than in adults, with a lower threshold of pain, a higher psychological impact, long-term damages. And so that's also why in this project we wanted to focus, well, within this program and other project that we currently have, we wanted to focus on identifying torture, trying to find the best ways to do so, and reflect on the assistance that could be given afterwards. At the OMCT, we mostly focus on detention settings, and in particular criminal detention settings. We have seen that if torture is invisible, it's even more invisible within detention settings, where children are really cut from the outside world, with very limited contact with their families or their lawyers, depending on the country, and where it's maybe easier to be the victims of torture that would go unreported, would go unidentified. And in addition, here the aspect of discipline and of discipline teenagers that would have committed a crime has let's say has even more space, as it would be construed by maybe the public opinion or the actors of the detention system, of the judicial system, as children that should be disciplined for what they've done. So obviously the need to document torture is needed to identify what will be done next, both on an individual level, as it's been also indicated in the previous presentation, but also on structural changes. And that's what we also try to do at OMCT. Like, once we've identified some patterns, or not even patterns, individual cases, but also patterns, to have discussions with the penitentiary authorities, with ministries, and try to see and to give also some trainings to the key stakeholders of the juvenile justice system, or of the penitentiary agency, to discuss a little bit around the concept of torture children, the practices that are being conducted, and how to find common grounds on the way children are treated, and obviously on an individual level, the referral of children and assistance that they can provide within our project. In addition to specific referral of children, we actually provide, through our network members and partners, psychological assistance along the detention. So that's not only for children that have been subjected to torture, but children detained in general, and medical attention if needed. And obviously trying to understand a little bit more broadly the phenomenon of torture in children, and be able to use those information in the advocacy that we conduct. And basically, one of the key things that we are doing in this framework, in the identification of torture, is the monitoring of child detention facility, which is a key steps. We do this through our partners that monitor regularly child detention, and have discussions with both children and with the detention staff and the detention authorities, And also the fact to monitor regularly is also itself a form of prevention and deterrence of torture, because the authorities know that some organizations have an outside look in the facilities, that basically someone is sort of paying attention to those children, and the regularity of the visit can also sort of act as a prevention. And in addition to physical or psychological torture, we also look at detention conditions that can also be a form of ill treatment, a form of torture, depending on how harsh they are. Obviously, we can discuss any type of definition, but let's say we also look at inhuman condition of detention. If children, for instance, the prison are so overcrowded that they have to take turn to sleep because there is not enough space, we can debate, but it's true that we sort of look at it at this from a larger perspective. I would say yes, not thinking of maybe a particularly defined study as it was the case in the previous study, but to improve the detention condition of children. Yes. And basically for this, we also discuss and train the partners that we work with on exactly how the monitoring should be done, and what are the different things that different items, different elements that should be looked at when I'm trying to identify and documenting the detention conditions, and especially child torture. So I'll just be quite brief, but basically looking at the facilities used by children and whether they comply with international juvenile justice and international detention standards, collecting information on the situation of children, accommodation, food access to medication, access to doctors, all the interactions with prison guards, with educators, contact with family, the possibility for children to complain, which is an aspect that is extremely difficult in practice to have, for this to be meaningful. It's one of the international provision, but it's extremely difficult to actually have in practice, both in terms of potential reprisals, the confidentiality of the complaint mechanisms, and as I was saying, deterrence to detect occurrences of torture. As was said in the previous presentation, we also conduct interviews with children, which also answer to quite a wide range of principles to protect the children in question. And that also helps, obviously, to identify cases. So cross-checking facts, discussing with the penitentiary authorities, so that the cases of torture can be identified with a purpose to both discuss with the authorities so that the practices stop, but also to build cases and provide the relevant assistance that the children need. Well, obviously, this is done by us and civil society partners, but in coordination with other key professionals. I'll go back there a bit later to the role of civil society, but obviously this is not the only actor, and it has to involve a wide range of professionals that can bring specific specific support. Sometimes in detention facilities, those kind of supports are not easy to provide to the children. I mean, there maybe no doctors on site or visiting regularly. So that the role of civil society here would be to identify cases where it's extremely needed and waiting for a more structural change. Obviously, the definition of torture, as I said a little bit earlier, sometimes quite difficult, also in terms of monitoring and screening and documenting. So that also has to be clear, both from the people that are conducting the identification, but also when discussing later with the authorities that we would like to confront the situation with. And I think I'll go a little bit deeper into the interview with children that are deprived of liberty, as this is something that we approach extremely carefully, with obviously the main aspect being to answer to the principles of doing no harm. So it has to be done according to specific standards. Obviously, the idea is to try to understand the situation and what happens, which, while obviously protecting the children in question, trying to establish an exchange based on trust with the children, cross-checking facts, discussing with different children and also different stakeholders, but obviously always answering and respecting fundamental principles of confidentiality and anonymity on a voluntary basis, and never forcing a child to speak with partners if they don't want to, and obviously assessing any risks of reprisals, any risks that the children could face when even by speaking to civil society, and even more when disclosing any practice that may have taken place. And it's something that we insist as much as possible with the partners that conduct the regular visits. And I think I'm done. I'm not sure I exhausted the time that was allocated to me, but I think I'll stop there, and yeah, feel free to ask any questions, obviously.
It is perfect, Laure, because we're a bit behind the time, so we can actually take a couple of questions now before we go on to Kim. Thank you for your presentation, Laure. Yeah. So now we have some space for a couple of questions. If anyone has any questions to Laure's presentation. Otherwise, we go directly to Kim. No questions. Okay. Everything was super clear. Oh. Okay, Kim. So we'll go to the next participant, Kim. And let me try to pronounce your name. Your surname, Kim Baranowski. She has different hats. As Associate Director at Mount Sinai Human Rights Program. She's also Senior Advisor at Trauma Consortium at Nahlén Hospital. And she's also the representative to the United Nations American Psychological Association. So the floor is yours, Kim, and we can see your screen perfectly. your presentation.
Fantastic. I'm thrilled to be joining everyone today as a part of the webinar. And in my session, I'm going to be providing a brief orientation to the forensic psychological evaluation of children and minors, specifically to document evidence of torture and persecution. So I think all of our presentations dovetail really beautifully together today. I have no conflicts of interest to disclose. And of course, because we're discussing topics related to violence, please take care of yourself in any way that you may need. So in our work, we do a lot of forensic evaluations, physical, gynecological, and psychological. As a psychologist, I'm going to be focusing on the psychological evaluation of asylum seekers. The minors that we work with reported a range of experiences related to pre-migration, migration, and post-migration violence and ill treatment. Most often, the children that we work with report blunt trauma. So they report experiences where they have been beaten, kicked, or hit with objects. But as you can see, the reported abuses also include violence such as trafficking, kidnapping, forced marriage, and sexual assault. Individuals across the lifespan may have diverse reactions and responses to an exposure of torture. There are common psychological sequelae associated with these experiences. Primarily, as mentioned earlier, we see depression, anxiety, and PTSD-related symptomology most commonly reported by individuals who have experienced torture and persecution. However, the responses of children may not always be adequately captured through the use of formal diagnostic criteria. So I'll talk a little bit more today about some of the things that folks can keep an eye out for when documenting exposure to torture, trauma, and persecution in young people. And this is essential because if child-specific responses are not recognized, misunderstandings and misdiagnosis and an incomplete picture of the rate of torture in children can be lost. So when we looked at the experiences of the minors that we serve, that we're conducting formal forensic evaluations of, we found that the children that we serve most commonly reported symptoms associated with PTSD, depression, and anxiety. However, our trained forensic evaluators also found high rates of suicidal ideation and in some cases past suicide attempts in children, as well as self-injurious behavior. So cutting, hitting, and pinching oneself in an effort to cope with the distress that they experienced following an exposure to torture. It should also be noted that children can report symptoms consistent with separation anxiety, specific phobias, conduct disorder, and other DSM-5 criteria. However, in our clients, most commonly, it's PTSD, anxiety, depression, and suicidal ideation. We do use the Istanbul Protocol guidelines for documenting evidence of torture in children. And the Istanbul Protocol does provide some child-specific guidelines. However, I think as everyone has mentioned so far this day, we can really do better as a field in developing specific responses to effectively document, monitor, and screen for torture in children. And I think the development of these best practices is really an important task that we can all leverage our unique skills and expertise to do. So for folks who might be a little less familiar with the forensic psychological evaluation of children exposed to persecution, ill treatment, and torture, essentially we're asking the following questions that are highlighted in the Istanbul Protocol. And the resulting affidavit that the clinical professional provides can offer a unique opportunity to contextualize the child's responses in a very culturally appropriate and developmentally appropriate way to really offer the judiciary a nuanced understanding for why the particular symptoms and behaviors that we see in children might be reflective of an exposure to abuse. And the forensic evaluation is really essential because in the United States, the rates of being granted asylum without such an evaluation are about 42%. And research has demonstrated that when we have a formal affidavit written by a trained clinical professional who's documenting evidence, the grant rate can increase to about 81%. So ensuring that children exposed to ill treatment and torture have access to these pro bono forensic evaluations is essential. The well-being of the child, as well as their best interests, is paramount when documenting evidence of persecution, torture, and ill treatment. And we've spoken about the essential need for consent in engaging in any sort of interview or documentation process. However, children are unable to provide informed consent, and they require the consent to come from a legal guardian. And when we're thinking about, for example, unaccompanied minors, this can get quite complicated because we need to determine who is eligible and who is appropriate to offer this informed consent for a child to participate. So together, clinical professionals and hopefully legal teams who are working to ensure that children are able to access their right to apply for protected immigration status need to identify who is this person who can provide consent, who is protecting the child's story, as well as developing very explicit guidelines for the child's assent. So ensuring that even though the child cannot provide legal consent, they are voluntarily agreeing to participate in evaluation. So children's cognition and memory are impacted by their development, the traumas they have experienced, and the context of the ill treatment they have endured. And the development of the processes that we typically would expect in memory, adult processes of memory, take a while for children to develop and may be delayed in children who've been exposed to severe trauma and torture. So we really want to be mindful of the fact that children will encounter many of the same responses in terms of their memory. For example, traumatic memory that is fragmented, difficulties in arranging traumatic memories chronologically. So this happened first, then that happened. You know, children may also avoid and suppress memories the way adults do. In addition to the fact that children's developmental levels may make them less able to provide a clear and coherent narrative. So clinical professionals can really advocate in terms of helping, the powers that be, whoever might be determining, the eventual placement of the child, whether they'll be deported, whether they'll be granted sanctuary in their host country, to help them understand why traumatic memory might be very difficult for children to navigate, and that this isn't necessarily a function of credibility, that it actually might be reflective of the child's exposure to severe trauma. So we've discussed a little bit about the care that needs to be taken when documenting torture in children, and focus on rapport building, on developing a safe relationship is essential. And it might take longer than we would see rapport building in adults. So we have to be very patient. We're going to want to adjust our language so that we're speaking in a way that is developmentally appropriate to the child, that we are engaging in responding to the child in a way that will be supportive and helping them feel safe, making sure that the settings are as informal and comfortable as possible for these types of interviews and evaluations. It's essential that we follow the child's pacing, that we are actively looking to ensure that re-traumatization will not occur, And one of the ways that we do that is by looking at the child's responses. And if we notice they're becoming emotionally flooded, we take a break. We might shift our questioning or our conversation to a topic area that is less fraught for the child. In addition, because children might struggle in identifying how their exposure to torture has experienced them psychologically, we can include collateral information from parents and other important caregivers who can speak to the way that the child seems to have been impacted from their perspective. So because children may not voluntarily report trauma symptoms, and that young children might actually tend towards withdrawal, older children might tend towards denying that symptoms exist because of stigma, we can use many strategies to try to gather information. We've spoken a little bit already today about screening tools and measures, so questionnaires, thinking about culturally responsive and developmentally appropriate descriptions. So children might not speak explicitly to rape, but they'll talk about being hurt. So using the term being hurt, because that's the child's term, is really important. So symptom presentation can vary, and children might rely less commonly on a verbal report. So we want to think about behavioral observation as a really important tool. There was an earlier question about somatic reactions, and yes, inquiring into headaches, gastrointestinal distress, pain, fatigue can be important markers of exposure to torture in children. Another thing we can look at is the way that behavioral patterns have changed prior to the torture experience and afterwards, as well as thinking about psychosocial context in what a distressing or concerning reaction according to the individual child's cultural norms might be. So in young children, we often see hyperarousal as a signature response to exposure to torture or trauma, and that can manifest in the child being restless, having sleep disturbances, being more irritable than was previously seen, having an exaggerated startle response, as well as avoidance behaviors. So children might be presenting with more fear and aggression than they previously had. They might be presenting with inappropriate sexual behavior given their age and developmental stage. A preoccupation with the trauma, so asking lots of questions, for example, about the trauma, as well as repetitive play that is reminiscent of the trauma experience. They might have incontinence or bedwetting, eating disturbances, and we mentioned already somatic reactions. Dissociation also might be prominent in young children. So in a study of parents who had children that had been exposed to a traumatic experience, about 45% of the parents said that they saw dissociation in their children. And this was exhibited by the child being non-responsive, appearing spaced out, psychologically distanced or shut down, as well as having flashbacks, which was seen as yelling words or crying or having bodily reactions reminiscent of the trauma. So the child actually taking a physical posture that was reminiscent of their experience of torture. In older children, we might see alterations in their personality. They might begin to isolate from peers. They might engage in reckless or self-harming behavior. They might begin to exhibit disordered eating, substance use, or new sexual activity. So we've been focusing a lot on problems or issues that manifest following the exposure to torture, persecution, or ill treatment. But it's important to note that the minors and children that we have worked with also report a range of resilience factors that they have identified as being helpful to them in coping with their exposure to abuse. Many young people report a spiritual or religious orientation, so a connection to a higher power, access to familial and social support, flexibility cognitively and emotionally, so the ability to reframe their experience in a way that feels helpful to them, having a sense of meaning In many cases, the children want to help their families. They want to help others who maybe have been exposed to similar experiences. Their focus on education is viewed as a strength and a support, as well as engagement in activities that they find meaningful. So one of the ways that we can start to assess and document these resilience factors is by including strengths-based interview prompts as we work with young people, as well as acknowledging the strength and courage that it takes for a child to participate in a documentation process. A lot of difficult feelings can come up, and it takes a lot of bravery for them to agree to and participate in this type of documentation process. So clinical professionals can think about many things they might do following the evaluation to support a child and their family who've been exposed to torture. One of the things we often think about is activating supportive resources in the community, for example, medical and psychological referrals. But it's important to also be mindful of the fact that folks who do not yet have protected immigration status may not be eligible for some governmental programs, and because of their experience of persecution, might be quite fearful of engaging with governmental referral sources. So to be really mindful and sensitive to that. So one of the things we can do is we can think about civil society. We can think about familiar local organizations that may offer supportive services to clients in a way that feels safer and more comfortable. Parents can also be supported. So what can parents do, and how can we help them respond to their children in a way that could be useful and growth promoting? So encouraging families to assure the child that they are safe in their school, at home, and in their community. Children often blame themselves and might experience a lot of guilt and shame. So explaining to the child sometimes again and again and again that they are not responsible for the traumatic event. To be patient. Healing takes time. There is no certain time that healing should be completed. So encouraging the family and the children to be patient with themselves, as well as to encourage the family to connect with formal supports. And these can also be Indigenous healing systems and Indigenous support systems, religious leaders, as well as doctors and counselors and legal professionals. We know that asylum seekers, refugees, and other individuals who've been exposed to trauma and persecution benefit from social integration. So one of the ways we can support children following their exposure to torture is by supporting their family in being socially integrated. So as professionals, we can advocate for vocational training and employment. Of course, financial support is so important. Access to legal protections, medical care, and psychological care. Sure, thank you. As well as encouraging families to connect with culturally similar others who are already well integrated into their communities. So we know that diaspora communities can provide survivors of torture with really important and trustworthy information. So helping to connect families with members of their diaspora community can potentially be very helpful. So interventions in terms of the empirically supported responses to torture can take many forms. We've already mentioned cognitive behavioral therapy, so verbal processing of the traumatic event, reflective exercises, so self-exploration, exploration of stories, self-soothing and distress tolerance skills, case management, interpersonal skills, so strategies to develop healthy relationships that are consistent with the values of the child and their family. Psychoeducation is very important. The idea that we can normalize expected responses to trauma so folks can feel validated and affirmed and know that how they're thinking, feeling, and behaving is what we would expect to see given what they've encountered, as well as creative approaches, drama, music, art. And I wanted to end here with the minors that we have worked with. We've been interviewing adults who were minor asylum seekers, so adults who experienced violence and persecution as children who are now in the United States seeking safety. And they identified many external supports. Notably, the supports that they identified were not clinical professionals off the bat. And I think this offers folks in the medical and mental health fields with an opportunity to partner with families, peers, legal professionals, and school staff. Schools are very effective places for children to get support. There's not so much of a stigmatizing kind of feel to it. They're already working closely with families. And then the adults that we interviewed reported that as children, their own sense of optimism and gratitude, as well as their focus on their own growth and self-reliance, were really impactful in helping them feel as if they were coping in a way that supported their well-being. So I am going to now open things up for questions, and I'm happy to speak with folks about anything that I can provide more information about.
Thank you, Kim. Thank you so much for this excellent presentation. I can see a hand up from Alexis. Allez-y, Alexis. Make sure the others are on the English channel to get the interpretation.
Oui.
Alexis?
Bon, merci pour la parole. Et j'avais très bien suivi cette intervention. Moi, je vais parler sur l'évaluation des enfants torturés. Il peut arriver que les enfants développent un certain nombre de problèmes. Ces problèmes sont liés au délire, au cauchemar, et que ces problèmes persistent. Maintenant, lorsque les psychologues sont en train de travailler avec l'enfant qui présente ces délires, ces cauchemars, l'enfant ne va pas donner des éléments satisfaisants. Est-ce que dans ces conditions, le psychologue ne peut pas travailler avec les parents de cet enfant parce que ce sont eux qui sont avec les enfants les jours comme la nuit pour les aider quand même à trouver une solution? C'était ça ma préoccupation.
I think that's a very excellent point. And that's where I feel like mental health professionals, psychologists, and others can really function as collaborators and consultants to families. So we might not always represent the most trusted source of information to a child. I think we can do a good job of trying to establish that trust, but families and others in the child's life who might have more sway or might have more significance can deliver that information potentially in a way that would be more helpful and useful to the child. So I do think working closely with parents and offering them strategies that they can offer their children can be a really effective way. They are an expert on their child. They are an expert on their family. And so by really honoring their expertise and offering them a range of potential responses, we might be most effective in supporting the child.
Thanks, Kim. I don't know if Ronak, Catarina, Laure, if you want to add anything to these questions. Now it's kind of open discussion, so feel free to add. I'm not sure if there are any other comments. Miriam from TRC Palestine is asking in the chat, what happens in the case where the child's parent or legal guardian is the one who is abusing the child? And informed consent is difficult to obtain for forensic evidence. Good question, Miriam.
I'm happy to offer a possible option. which is in some nations, a guardian can be appointed to a child. In that case, that person could offer the informed consent. And another thing that I'm so glad you asked this question, because I didn't mention, is that the presence of a trusted caregiver or parent during the evaluation might be helpful. However, if that particular individual has engaged in ill treatment towards the child, it can compromise the child's safety. So really determining the presence of adults in the child's life during the evaluation, as well as who would be most appropriate to be able to determine whether the child would benefit or should participate in evaluation, may not always be the parent. So thank you for that.
There's also Angeliki from the Helen Bamber Foundation. She's asking that one of the challenges she has when assessing young unaccompanied asylum seekers for medical legal purposes is the lack of collateral information, especially comorbidity, which makes it challenging to address causation questions often asked by solicitors regarding cognitive difficulties. How do you tend to address this?
I think this is a very difficult issue, as you mentioned in your question. There are some cases, for example, if there is concerns about kind of cognitive issues that really expand beyond the memory and attention difficulties that we typically see with depression and anxiety and PTSD symptomology, a formal neuropsych assessment may be warranted. However, those are very, very difficult to access for children. So I agree. If we are especially working with young children and we are hoping for that collateral information and it doesn't exist, sometimes relying on other experts can support the legal team in making a valuable and important claim for the child.
Thanks, Kim. Again, feel free, Catarina, Ronak, Laure, if you want to say something. I'm just pulling out the questions here. There's another question from Nida. She says, sometimes growing age causes psychological and behavioral changes. How can we differentiate that the behavioral change is because of torture or because of hormonal change? No one knows, right? It's kind of difficult to assess. I'll pull out the next question from Okora Joel Opillo. Thanks for the presentation. May you clarify on child safeguarding processes versus content and care of unaccompanied minors? Joel from Uganda. I'm not sure if I really understand child guarding processes versus consent and care of unaccompanied minors. Yes. If you want to, Joel, you can go on mic and clarify a bit more. Otherwise, the others feel free to jump on mic.
Yes, hello?
Hello, Joel.
Yes, thank you very much. I would like to get more clarity. We have what we call child safeguarding policies where any person below age of 18 in Uganda is not supposed to be answering questions without consent from a minor, though from 7 onwards can ascend. So while you are trying to interview them, these are also the dynamics that also you have to face in the field. And you find the child is alone, unaccompanied. How do you balance these two equations? You're supposed to, yes, continue providing your service, but also if you do and you're alone, even the perpetrator can still say, yes, you're the one who has taken the child, so, and can lodge another case against you. So what do we do there? Thank you.
I'm happy to jump in. The others, can too, to piggyback. But we, in my experience with my program, we are only interviewing and assessing children who have informed consent from a legal guardian. So, and the main reason for that is the context of the U.S. immigration process in terms of the immigration hearings and judicial system. So that's a very good question. All of the cases in which we are working with, there is a guardian or a parent who is able to legally consent for that child.
Thank you.
Okay. Well, unless the legal guardian is the perpetrator, as Miriam pointed out, right? Yeah. Well, I don't see any more questions. Does anyone have any further questions? Otherwise, I think we actually reached the end. We're over 4 minutes. I want to really thank the speakers, Kim, Ronak, Catarina, Laure, for being here with us today. Feel free to, if you want to share in the chat your contact, or I don't know, if you want to share anything but anyway, we will be sharing the recording of the session and material, if the presenters allow us to, in our e-learning Fabo site. I will put it now in the chat so you all remember. But yeah, last and not least, we have the famous poll with 3 questions that I'm gonna be sharing now. So you see it. So you see it in your screen. Now you should be seeing the satisfaction survey on your screen, which we really, really, really appreciate if you can fill in, because this is gonna help us improve the spacers and understand if they are relevant, readapt, etc., etc. So please it takes half minute to complete it. Good, and I see Ronak, Catarina, and Kim are sharing their contacts here. Good. And people are responding. It's always good to see faces again on screen from different parts of the world. Good. Well, with that, I think we'll close here. Thank you, everyone, again.
Thank you.
And
so
have
much.
a good afternoon, evening, morning, whatever you are. Thank you so much.
Thank
Bye
you.
bye.
Bye.
Bye, Catarina, Ronak, Laure, Kim,
À la prochaine.
Ludmila,
Au
Alexis, à la
revoir.
prochaine. Sladiana.
Bye. Thank
À la
you.
prochaine. Bye. Bye, Airam.